Welcome, everyone, and thank you so much for joining us for this webinar specifically on spotting and managing behavioral health conditions in jails and jail homes. It is my pleasure to introduce our guest, Dr. Norm Hoffman. Before I do that, just a couple of very quick housekeeping items. First is a question, the number one question that often comes in is whether there will be CEUs attached to today's webinar. The answer is no. So I want to just make sure everyone is aware this is for our own edification today, no CEUs. Secondly, we are recording this webinar and we'll be sending out a recording to everyone who's registered Monday morning or afternoon. So that's something you can watch for, and feel free to share that out with your colleagues who may not be here, and everyone who is registered will receive that recording. So fear not if you have to jump out early, or if you have colleagues who weren't able to attend. There is a Q&A panel available at the bottom of your Zoom window. We encourage you, as you're listening to today's presentation, to click into that Q&A panel and pose any questions that you have for Dr. Hoffman today. We're going to do our very best at the end of the webinar, possibly even at moments throughout the webinar, to make sure that we capture and address as many of those questions as possible. Okay, now without further ado, I would like to introduce you all to Dr. Norm Hoffman. Dr. Hoffman is a clinical psychologist who is nationally and internationally recognized expert in the clinical assessment of mental health and substance use disorders and in the evaluation of behavioral health programs. He has worked with private organizations and governmental agencies in a variety of states and countries. Dr. Hoffman developed assessment instruments used throughout the United States and Canada, as well as in several European countries. Instruments include brief screens, detailed diagnostic interviews, and treatment planning aids. He was the founder and science officer for the largest independent outcome evaluation system in the US and has authored or co-authored more than 220 publications. Norm, I will just add, is also the founder of Events Diagnostics. The Change Companies is really proud to partner with his organization to distribute the really sound tools and resources that Norm and his team have created and validated over the years. So I'm going to go ahead and share my screen, and without further ado, welcome Dr. Hoffman to today's webinar.
Okay, thank you very much. As we click on the different screens, we're going to be focusing on assessment issues and screening and assessment, that is, rather than treatment placement and level of care. Level of care is often, I think, overemphasized, and I say that as the individual who led the team that developed the first multi-level of care criteria in the country, which were the Cleveland criteria, developed in 1987 is when they were published. They also became the foundation for the first ever ASAM patient placement criteria, published in 91. And I was privileged to be the lead author on those as well. Now, screening and assessment are often confused. Screening is a probability guesstimate that you are likely to have a given condition. Now, screens are not something on which you would make a life-altering decision. For example, screens are in the medical field are things like mammograms and colonoscopies. But you wouldn't make a medical decision based on those alone in terms of treatment. You would want the assessment of the biopsy as the definitive determination. To an extent, the same thing applies in the behavioral health area. Screens actually are often most useful in whom they exclude from further assessment. For example, about 50% of first-time DUI offenders will not meet a DSM-5 diagnosis. They might hit some alternate designation like zip damn fool or dumbass, but they will not get a DSM-5 diagnosis. So a screen that would weed out those people that should get education and sanctions or whatever the appropriate disposition is from those who will require additional services to keep them from getting rearrested. Um, we do have a triage tool called the TAD, T-A-A-D, that is between a screen and an assessment. It covers all the 11 criteria for a substance use disorder, but it's not as thorough as a true assessment tool is. One thing we found with that is that the people that the TAD indicates are up in the serious or the severe substance use category for alcohol are much more likely to have reported an accident in their history. So it may be that those individuals with diagnoses may be the more dangerous ones on the road because they will drive much more frequently under the influence as opposed to somebody who just makes a miscalculation. Um, so also we see with the screening and the TAD that not everybody who gets arrested is appropriate for getting clinical services. So they're not automatically uh, in the running for a diagnosis. Assessments, on the other hand, should be comprehensive, usually in the form of a structured diagnostic interview. And a thorough assessment is really a key component of developing a defensible treatment plan. Uh, in talking with people from CARF and the Joint Commission, I find that they often tell me that the assessment components are the weakest link they find in a lot of treatment programs. So if we can go to the next slide, starting with uh, screening tools. If you have any familiarity with the field, you're probably familiar with some of the common old screening tools like the cage and the mast, and some of the newer instruments that are also screens designed for jail applications. Where they get the item selection from is somewhat in question for a lot of these screens. In looking at the items, you often think that they used a DRE method for selecting the items. For those of you who are not familiar with DRE, that stands for direct rectal extraction. The UNCOPE, however, was very meticulously developed for ADAM, which is the arrestee drug abuse monitoring system that monitors urine analyses results in jurisdictions around the country. And they needed some quick way of determining whether uh, an individual was a casual user or actually had a substance use disorder. Uh, so to do that, we reviewed some of the assessment tools that were out there at the time, um, filtered it through my two decades of experience in the field, and selected about 15 items that we thought might be good candidates for screening. We found out that if using the full 15 items actually produced poorer results than the UNCOPE, because when we used the full 15 items, we often had more than one item loading on a given criterion, and that tended to produce false positives. And also, if we picked items that were less prevalent, then we were going to probably get some false negatives. One of those is if you're looking at the CAPE, I mean uh, the cage screen, the E item is an eye opener, which is a late stage symptom, and you wouldn't want a late stage symptom in a screen that you wanted to find people at the earlier stages of their addiction. So in refining the UNCOPE or the set of items against a structured diagnostic interview, the UNCOPE emerged as the most powerful and accurate screen. The first 5 items map to 5 different DSM-5 criteria, and the E item is a self-medication sort of item. So we have unplanned use, neglect of responsibilities, cutting down or trying to cut down, objections by others, and the preoccupation question is a surrogate for craving. So those are the 5 criterion items in the UNCOPE. Uh, the actual precise wording can be altered a little bit. Whether you say ask whether the person spent a great deal of time using or if they used a greater quantity. Probably is not going to alter the results that much. Questions like has anyone objected? Uh, Definitely should be focused on whether or not they've objected. Again, the cage is an example of a screen I often use in trainings of how not to do a screen. Has the item on, are you annoyed by people objecting to your drinking? And I always remember a gentleman that I was interviewing when I was doing some part-time work in a private practice. I asked him if anybody objected, and he looked me in the eye and he said, "Well, heck, Doc, I told you I was married." He considered objections by a spouse as being a normal part of the marriage arrangement. Was he annoyed? No. But did somebody object? Oh, yes. Object she did. So we have the uncoped screen as being one that tends to give you about a 90% accuracy rate, give or take. If we look at the next slide, we'll see that if you drill down to a specific substance, you get even better accuracies. And there is a seesaw involved in screening that you cannot avoid. If you want to minimize false positives, you must accept more false negatives. If you want to minimize false negatives, that is to say, increase the what's called specificity, then you have to accept more false errors in the other direction. So if your false positives should be repressed because you want to have everybody positive, the screen's positive, then you're going to have to accept a higher rate of false negatives. So here we see that the false positive rate goes from about 1% to 6%. The false negative rate is higher, and here it ranges from about 15% or 14% rather to about 6%. Also, you will notice that the sensitivity, that is the ability to detect those people that have a problem, being lower for alcohol and cannabis. I'm not quite sure why that is, other than the fact that alcohol and cannabis tend to have more of a distribution across the severity levels than the other drugs. With the cocaine, opiates, and stimulants, you tend to get an all or nothing. You get a bimodal U-shaped distribution of prevalence of those people who don't have any indication of a diagnosis versus those who are positive on, say, 8, 9 of the 11 diagnostic criteria. So in that sense, screening for opiates and meth are possibly more efficient. Some time ago, there was a big surge of interest in, do we need to get a special screen for opiates? And my response was, no, just ask about opiates and use the UNCOPE. That'll get you about the same place. One other thing about screening, before we go on to the next set of screens that we're going to talk about for mental health. Screening for substance use disorders in jail populations is dependent on who is doing the screening. Some years ago, we thought we were very clever in getting the UNCOPE embedded in the classification process at a local jail. And I had a research assistant doing interviews with the same people, coming up with high rates of substance issues. And I'm sure it'll be an amazing fact for all the people on this webinar to find out that recent arrestees tend to lie to cops. So the screening has to be done by somebody who's not a sworn officer. The arrestees do not necessarily tell police officers the truth. So if you're going to do screenings in a jail setting, the screening should be done either by the people that are doing maybe the medical workups, because medical workups are required by statute that you have to review the person's medical status. But you could even use a screen like the UNCOPE with a volunteer who works in a jail, a peer support person, somebody who's not identified as an authority figure. So you do have to take those kinds of special considerations under advisement when you're dealing with um, people in the correctional facilities. Next slide, we're going to look at some other screens.
Really quick, Norm, before we go into the additional screens, we did have a question about whether there's a manual available for the Uncope.
There is no manual. Um, there are, if you Google Uncope, you'll find all kinds of applications for the Uncope, not just in corrections, but in all kinds of settings. Um, the basic rule of thumb is 3 or more positive items gets you into risk for a serious, severe substance use disorder. Um, because if you get a score of 3 positive items on the Uncope, you're virtually assured of a diagnosis because you're going to document at least 2 criterion. Um, and if you want to lower that threshold to 2, then you will get a higher sensitivity. That is to say, you'll have fewer false positives, but you will get a larger number of false positives instead of, so you have to sacrifice some false positives for not having any false negatives or having lower rate of false negatives. So there's no real manual to be had with the uncope other than deciding how the different errors are important to you. So if you absolutely don't want to get anybody that is a false positive, if you raised the threshold to 4, I'll virtually guarantee you there'll be no false positives, but you will get a substantial number of false negatives with that. I don't know if that will answer the question or not, but that's the best I can do for now. With regard to PTSD and depression, we came up with two item screens to give us a hint as whether or not an individual has a diagnosable condition for either one of these two. So if you get 2 positive responses to the items, you would flag the person in as probably having that condition. If you don't get both items positive, you would declare them to be a negative on that. The reason we chose PTSD and depression is because they are among the most prevalent mental health conditions that we have found in most jail populations, and indeed in prison populations as well, where the CAPE has been used. These are the 2 mental health conditions that are going to be most prevalent in these correctional populations. If we can have the next slide. As you can see, the sensitivity and specificity for these is not as good as the Uncope, but that's understandable because these screens did not go through the rigorous development process that the Uncope screen has gone through. But it still gives us a fairly decent hit on whether or not the individual is likely to have a problem in these areas. So with 10 items, you can screen for the most prevalent conditions in a typical jail population. And if you can go to the next slide, excuse me. We've been using the CAPE, both 4 initially and the CAPE 5, which is the 5 designation means that it's compatible with the DSM-5. And the CAPE covers all of the mental health, all of the substance use conditions very thoroughly. And in varying degrees of depth, it covers mental health conditions likely to co-occur. The first time we used a CAPE was in my own county because the sheriff at the time was a friend of mine. And he said, Norm, I've got all these guys in my jail with drug and alcohol problems and mental health issues, but I can't prove it. So I recruited a graduate student at the University or the Western Carolina University, a nearby university to where I live. And the change companies donated some of the CAPE booklets, a couple of hundred of those, to do the evaluation. And so the graduate student did all the interviews, and she would then turn them over to me, and I would key them in by hand into Excel spreadsheets, the responses from the CAPE for analysis. It took her about 35 to 50 minutes, depending on how much the person had. If the individual had no to minimal substance-related issues, the interview would go quite quickly. If they did have a lot of substance abuse in their history, they would take longer. The interviews focus on the past 12 months, which is what the DSM-5 requires for a current diagnosis. This gets into one of the interesting issues of how the wording is done, in that we always couch the CAPE items as events that have occurred in the last 12 months or from this time last year. We do not use the term, has this occurred for you in the last year? Because if you're doing the evaluation, say here in November, the person is going to count from January 1 on and not tell you about all the things that went down over the holidays. So you always want to couch it in terms of the last 12 months from this time last year, so that you do capture events that have occurred in a full 12-month period. The other thing the CAPE does is it documents reoccurrence of the same event. So for a lot of things, most of the items, except for tolerance, which doesn't vary or doesn't reoccur, it asks for the amount of times this has occurred. So for example, you said that your alcohol was related to missing work. Did that happen 3 or more times or just once or twice in the last 12 months? So that you get documentation of reoccurrence, because the DSM-5 stipulates that it's a pattern of use that results in the consequences. And if you've documented a pattern of consequences, by default, you've documented a pattern of use as well. So the CAPE has been compared to some of the tools like the SKID, which is a research a tool that found that the CAPE actually did better for substance use disorders than the SKID when compared against clinical judgment, but was not as thorough for the mental health issues, which is understandable because that's the way the tool was designed. So what we found is that we were dealing with a rather enriched population, if you will, with individuals with substance use disorders, as you'll see in the next slide. We actually began then a series of studies with a colleague from Western Carolina University in the Department of Criminology. He and I wound up being involved in a number of studies of jail populations where the county had a grant or subsidized the interviewing of inmates to determine prevalence rates. And what we discovered when we knew the prevalence rate of substance use disorders in one county, we knew the prevalence rates of substance use disorders in one county. The prevalence rates varied, statistically significantly varied amongst the various counties. These data are from an article we've actually published on that, comparing 4 rural county jails. One of them actually in Florida, the others in North Carolina. And we found that the substance rates varied. We also very quickly discovered that in rural America, we're dealing with a meth epidemic, not so much as an opioid epidemic, because meth was one of the more prevalent severe diagnoses that we encountered. And in this case, it's the prevalence for moderate to severe, which vaguely correlates to dependence in the older criteria. We also found that opiate and stimulant dependence, or severe opiate and stimulant dependence, tended to co-occur, that people with one of these diagnoses tended to have the other. In contrast to alcohol, If you have a severe stimulant diagnosis, your odds of having a severe alcohol diagnosis are actually lower than the general jail population. So if you've got the really good stuff, you're not going to bother with the alcohol and the marijuana, which and cocaine in rural areas is very rarely encountered. Marijuana you do get. Um, I would draw your attention to the bars on the right hand of the screen in terms of people who have multiple severe substance use disorders. They range from a third to almost half. If we include the moderate diagnoses in these, those bars would all be up above 50%. Excuse me. So you're dealing with a complex population. I will get ahead of myself a little bit and talk about one of the sacred cows that we get often from the federal government, which is the issue of designate the primary substance versus the secondary substance. In reality, this is somewhat of a meaningless distinction. If you have a broken leg and a broken arm, which one is primary? So it's not that you have a specific substance that's more important necessarily than others. That may be the case in certain areas, but the whole concept of primary versus secondary drug really should be replaced with what are the patterns of substance use disorders that the individual is encountering. And we'll see that this has a financial implication as well as a clinical implication as we go along. And the next slide will show us the mental health stuff. This is similar to the substance use disorders, that when you know the prevalence rates in one county, you know the prevalence rates in one county. Um, it Some of the conditions tend not to be as varied. For example, PTSD tends to be in a tighter framework than some of the other conditions. But again, we see that the majority of people have at least one condition. And in fact, if you look at the bars on the far side, on the right-hand side, you'll find that the majority have multiple mental health issues that are impinging on their ability to deal with their drugs as well as dealing with their behaviors in some cases. One group that's not on this chart uh, consists of those individuals who have both manic and depressive episodes, also known as bipolar. Bipolar individuals in most jails that we've looked at have prevalence rates from about 5 to 10%, which is fairly low. But the bipolar individuals most of them will require some form of mood stabilizing medication to stay on an even keel. And the problem here is if the bipolar individual slips into a manic episode, a lot of what you're working on in terms of clinical counseling and the like is likely to go out the window temporarily, at least. And also, many people underestimate the degree to which the thinking and judgment get scrambled up in a manic episode. I remember one individual who suffered from bipolar and was stabilized, recounting to me that in a manic condition, approaching an intersection with a stoplight, trying to remember whether you drive on red or green. That's how confused the individual can be in a manic state. So the bipolar individual, while being represented in a very small portion of jail populations, still is somebody that if you detect the bipolar, you probably want to refer them to a physician to do some medication considerations. Next slide. Okay, so our case management issues is that we have at least 60% will have at least one serious SUD in most jails. and 50% will have multiple mental health conditions. So you're dealing with a relatively complicated clinical profile. And this has implications for not just your uh, referrals, but also what kinds of treatment programs you would hope to have in the community that could deal with these folks when they leave the jail. Because in most instances, an individual will be in the jail only a matter of weeks, if that. If they make bail and get out early, um, it's very unpredictable in working in jails as to how to get the individual plugged into treatment services. Again, I'm getting a little ahead of myself on this uh, point. One of the areas that I see as a real problem is bridging the gap from release from jail and service in the community. We did one study at a jail where I thought the treatment providers would be picking up cases and escorting them to the treatment program. Not one showed up because the problem is, although the individual inmate might qualify for Medicaid or Obamacare as the ACA, or might have some actual insurance, oftentimes it takes a while to get the qualification for the insurance or for the Medicaid. So you have a month or two of gap where the typical community treatment provider is not going to get paid. So one area that might be considered in county budgets is to provide some treatment funding for that gap from when the individual is first identified as having these issues and will qualify upon release for getting funded when they hit the community treatment programs. Next slide, please. Now, given all the PTSD, trauma-informed interventions might be appropriate as well. One of these that I've been very impressed with is called the Gurwe orchestration method, which was designed to deal with recidivists in the VA system initially, is what Dr. Gurwe was working on. And she developed a system of group interactions where the group is seated like an orchestra rather than in a circle. And in the front, there's a discloser or the soloist and the conductor, which is the facilitator. The soloist or discloser recounts an interest in his or her time, in his or her life that was traumatic, describes what factually happened, how the person felt, and what the person did. The other participants in the group are seated in two rows. The feelings row is the first one, and the action row is the second. As they're called upon, each person speculates what they would have felt in the feelings row, how they would have felt under those circumstances. The action row, as they are called upon one by one, there's no interaction amongst the group participants, uh, describes what they think they would have done had that occurred to them under those circumstances. So some things will be affirming in that people will react in the same way as the disclosure. Some will come up with totally different reactions. You know, one person might be embarrassed, another person might be angry. One person would have run away, another person would have struck out perhaps or did something else. Um, and so it modifies the event for the disclosure. And the group process then becomes part of that event. And then there are assignments that are assigned to the individuals between groups where they monitor their level of arousal, of how upset they become, and what kinds of triggers trigger that. And so it's a very different approach to dealing with trauma. We have also revised the ACEs, the Adverse Childhood Experiences Scale, to overcome some of the psychometric properties with the original. The R refers to breaking up the composite items into their components. And we have found, for example, that amongst the first three items, which deals with verbal, physical, and sexual assault, uh, that it's the more severe halves of those questions that are really related to an increased prevalence of PTSD as adults than the minor or the lesser severe events that have occurred. We've also replaced the yes/no response options with a 4-point Likert scale, excuse me, so that we can document reoccurrence of the same event over time. So trauma is definitely something that I think you need to incorporate into the treatment plan for a lot of these people. Next slide, please. So behavioral conditions matter. They impact public safety. They affect recidivism. They contribute to jail overcrowding, and they cost you money. And therein is where you can sometimes leverage some buy-in. If we can have the next slide. Um, oh, this one is a little out of place, but I'll deal with it here. I got it in the wrong spot. Uh, Multiple bookings are related to substance use disorders, obviously. And if somebody is injecting anything, that immediately increases the odds that they're going to be a recidivist. Injecting drugs is also a risk index indices for relapse. Anyone who's injecting substances into their veins has crossed a threshold many individuals who were addicted have not crossed. Um, so if you're going to uh, reduce the wear and tear, if you will, on your law enforcement officers, you need to address substance use disorders because every booking takes that book officer off the streets. And every booking for a pain in the butt, uh, intoxicated individual is going to occupy the officer's time instead of looking out for the other bad guys that are running around out there in the community. So dealing with substance use disorders can have a positive and salutary effect on law enforcement's trials and tribulations in the community, as well as taking the pressure off the jails, which in current times, in some counties, jails are quite overcrowded. And in some cases, they're even talking about expanding jail sizes to accommodate the population growth and the increased number of people that hit the uh, justice system. Next slide, please. One of the things we did in Haywood County was we looked at the number of days the individual was incarcerated and multiplied it by the per diem cost, which runs around $85 a day for most jails. It's the cost of having somebody in the jail. And we found out that if the individual had neither an opiate or a stimulant, severe diagnosis, on average over a 2-year period, they cost the county about $3,800. If they had either one of those diagnoses at the severe level, they cost the county $4,000 and change. And if they had both, which was about 10% of the population, they cost the county $6,000 and change. So the more severe diagnoses in these two conditions increase cost to the county. So it enables you to take a look at where the county might want to function or focus to reduce its own costs. And it also suggests that the possibility that if you can provide some funding for these bridge services that I mentioned earlier, that you will have a savings, possibly a net savings, but a savings in terms of the costs to the county budget, and not to mention the wear and tear, as I mentioned, on the law enforcement officers in dealing with these individuals that keep coming back to the jail repeatedly with due to their substance use issues or perhaps their mental health issues as well. I mentioned sacred cows before, the primary versus secondary substance. Another sacred cow in the corrections area is the issue of risk indices or risk indexes. Um, Risk indices are great for identifying subgroups. I mean, you can have a risk index that say can identify that 80% of this group is likely to be a recidivist versus 20% in that group, and make programming decisions based on which group the individual falls into. However, if you try and apply risk indices at the individual level, you run into some problems. Um, Even if you had a risk index that was 90% accurate on whether this person would be a recidivist, um, you would still be wrong, one person out of every 10. And I know of no risk index that's that accurate. Um, so risk indices are great when applied to groups. They should be viewed with caution when you're trying to apply them to the individual. Next slide, please. Okay, so what can sheriffs get out of all of this? Well, the first thing the sheriff in my county did was he got himself 4 more officers to do policing in the areas where the drug infestation, if you will, was appeared to be more pronounced. He also worked with the faith-based community to set up a homeless shelter next to the jail because he often asked inmates what they were going to do as they were leaving the jail, and he often found that they had no place to go. And he correctly surmised that somebody coming out of jail with whatever offense they had committed and not having any place to go was a good recipe for finding them back in your jail in another booking. So he worked with the faith-based community to set up a homeless shelter next to the jail. It serves not just people coming out of jail, but homeless shelter people often have drug issues as well, or mental health issues. He got a part-time counselor at the homeless shelter. Um, the current sheriff now has a full-time position to work with inmates as they're leaving the jail. And the county has set up a drug court where they're filtering in people where the substance use is intimately related to the offending. We did have one sheriff in Florida that used his data. He actually found that about 93% of his inmates had at least one substantial substance use disorder. He got used the data for supporting a $6 million funding initiative to set up a clinic in his county because his county didn't have one. In his county, you had to drive to the next county to get clinical services. And in some cases, that might entail like a 40-minute drive. So he's very anxious to get a clinic in his county to at least serve the people coming out of his jail. And that's not an unusual kind of situation, I think, to be in where the sheriffs in the county actually can benefit from finding out and documenting so they can prove it. As my friend, the former sheriff in Haywood County was saying, I need to prove that I've got these problem children in my jail. So it's not just the community that benefits, but even law enforcement can benefit. Next slide.
Really quick, Norm, a question was posed, is this research that can be done in prisons?
Yes.
Okay.
Yeah, we have the CAPE in some prisons. I just reviewed the data on one prison system that utilizes assessors in the local jurisdictions Um, they have about 140 people qualified to do the CAPE online so that they get consistent assessments across locations. And their prevalence rates in the uh, jail system, in the prison system tends to run a little lower than in the county jails. Excuse me, because county jails get everything that walks in the door, whereas people who are sentenced to prisons um, tend to have some of the more obvious cases removed from consideration and have not necessarily committed crimes that are um, warranting a protracted prison sentence, usually of 3 years or more. Um, and this one particular system is using the CAPE in the post-conviction pre-sentence evaluations so that the prison system has an understanding of who they're getting. And the judges have an understanding of what adjustments they might make under certain conditions, extenuating conditions based on their clinical profile. We'll leave this up during the rest of the session in case anybody wants to get a hold of me. The cell phone listed is usually on my belt or on my desk. And I do respond to emails as well. So feel free to contact me directly if you wish. I am at a stage in my career where I have time. I'm substantially retired, but not totally yet, and would be pleased to hear from anyone. Um, I I think there were some pre-questions posted.
Yes. Yes, absolutely. And we'll make sure to send out this contact information for Norm and provide some additional information on events um, in our follow-up email that gets sent out with the recording. One quick question that came up in the registration that I thought was really good is what recommendations do you have, Norm, for how to get more buy-in from court and criminal justice staff and leadership? What would you say to that?
Well, I think first thing is documenting the prevalence rates. The second thing I would do would be to look at those individuals who have severe substance use disorders or who have concurrent mental health conditions and what their offenses are. We had some somewhat titillating but not replicated event data because we didn't have the big database, but we did find indications that individuals who came up positive for PTSD and panic attacks were slightly more likely to have a violent offense in their charging sheets. Um, so that kind of makes clinical sense that if you have somebody who's subject to panic attacks and suffering from PTSD, he or she might act out when triggered. Um, and also people doing stimulants might be more likely to have violent charges in their record as well. That's a possibility. So you're dealing with a public health issue, a public safety issue, as well as a public health issue. Um, so I don't know if that got your question quite on point.
That was great, Norm. Thank you. One other
Okay,
question.
I did.
Oh, go
One
ahead.
thing did occur to me in your questioning that it triggered a thing from our background with the change companies. Years ago, about '08, we did a study looking at whether some of the change journals would affect recidivism. And we did a study where we looked at frequent flyers, that is, people who had been incarcerated at least once in the last 12 months prior to the current incarceration, and met criteria at the time for dependence on at least one substance. And we did a classic randomized clinical design where half the people got a journal and half the people got just a government booklet on addictions. And we found that the people who got the journal, as I recall, had about a 50% recidivism rate in the following 12 months, compared to 65% for those who got the pamphlet. Uh, the biggest problem we had in doing that study was getting a pencil to the inmates, because a regular length pencil could be used as a weapon in the eyes of the jail administration. So we had to use pencils that you use in a golf course, the little short stubby pencils that you use to fill out your scorecard. Uh, but we did document that for very little input and not even using the journal technically in the rigorous way it should be used, of just handing a journal and not following up with them to make sure that they had actually done any of the journaling. The other thing that was very interesting is that most of the inmates took the journal with them when they left. So there are some things that can be done at relatively little cost that might have some positive effect on individuals and whether or not they come back into the jail system or not.
Thank you so much, Norm. And yeah, we'll be sending out some information on we've we've now digitized the interactive journaling delivery system for jail. So these can be provided on the tablets. You don't have to worry about the pencil problem. And we'll send out some additional information on that as well. Norm, a great question from William. Thoughts on in-custody care coordination via community-based providers to increase that linkage to services upon release?
Run that one by me again.
What are your thoughts on
Well,
coordination, in custody care coordination via community-based providers to increase the linkage to services upon release?
absolutely. That's what the current sheriff in Haywood is doing by hiring an individual who works with the inmates upon release or prior to release, really, to try and get them connected to community services. I think it's important to get people uh, connected to services before they leave the jail, um, because otherwise, there's this tendency to not follow through. But if you're already familiar with the individuals you're going to be working with, you already know who's there, you have some comfort level with it, I think it increases the odds that the individual will follow through on that. Um, the big problem that I see is, though, that there can be a funding gap for the services. And I think if the one area that where I think county commissioners could make a contribution to reducing recidivism is in having a fund to cover some of the services from inside the jail to the community during that gap when the person might not yet have coverage if through, say, Medicaid or one of the other funding mechanisms that might be out there in whatever state you're working in.
Great. Well, I want to thank everyone who attended today and participated and provided some great questions during today's webinar. And particularly, Norm, want to thank you so much for this great information, for the great body of research that you've put together to give us these insights. Again, we'll be sharing out Norm's contact information and some link outs to the Atlas Digital platform, but also the events suite of offerings so that you can take a look at that. Norm, anything else to add on calls to action as we wrap up today's webinar?
Well, the CAPE is now online. As I mentioned, the one prison system uses it to coordinate the assessments across various jurisdictions. And that is a means of very economically documenting prevalence rates, because your biggest expense is going to be having somebody on the jail site to administer the interviews. But we do have that available.
Absolutely. So we'll provide information on all of those resources. And thank you, Norm, again. Thank you, everyone, for joining. We hope to see you again soon.